Hi, I'm Dr. Tom Buchholz. I'm a radiation oncologist, and I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, California. I welcome you to our discussion of breast cancer cases today. We really have an outstanding multidisciplinary panel, including breast surgical oncology, breast medical oncology, breast radiation oncology, and breast imaging or breast radiology. And I'd like each of our panelists to please introduce ourselves. Let's start with Dr. Mamounis, our breast surgical oncologist.
This is Terry Mamounis. As Tom mentioned, I'm a breast surgical oncologist, and I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute in Orlando, Florida.
Thank you, Dr. Mamounis. Dr. O'Shaughnessy.
Hello, everyone. I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research in the U.S. Oncology Clinical Trials Network in Dallas, Texas.
Thank you, Dr. O'Shaughnessy. Dr. Shaw.
Hello, I'm Chirag Shah. I'm a radiation oncologist at the Cleveland Clinic and serve as the Director of Breast Radiation Oncology and the Director of Clinical Research.
And the final member of our panel is Dr. Butler.
Hello, everyone. I'm Dr. Rennie Butler. I am Associate Professor at Yale University School of Medicine and Diagnostic Radiology, and I specialize in breast imaging.
Thank you, Dr. Butler. The next case is a little bit more unusual in terms of its histology. It's a 74-year-old with a 2.3 centimeter left breast cancer that was biopsy proven. Subsequent, after lumpectomy, was found to have a metaplastic or squamous cell carcinoma measuring 1 centimeter, grade 2, ER negative, PR negative, HER2 negative, associated also with a papillary carcinoma with DCIS present. There was a close margin for DCIS at 0.1 millimeter medially. 0 to 2 lymph nodes were involved. So she was pathologic stage 1. Would you offer chemotherapy options based on this histology? And how do we address the close surgical margin for DCIS? So before discussing these, we'll be talking a little bit about her history. She presented with a palpable mass in the breast, again, excellent performance status. She does have some medical conditions as shown here. She is a smoker for 10 years, but has quit. And again, a relatively extensive oncology history in both paternal and maternal sides. We're going to be taking a look at her imaging, but there's a lobular mass measuring 3.4 centimeters, an ultrasound confirming a mass in excess of 2 centimeters. Her pathology on the left side was a metaplastic squamous cell carcinoma, again measuring 1 centimeter in greatest dimension. The biomarkers, as described previously, as ER, PR, and HER2 negative. She did have a high-grade intracystic papillary carcinoma at 2 centimeters with DCIS present. The surgical margins, as mentioned, were negative. She did have Oncotype DX ordered and is pending. And she had 2 lymph nodes removed with her partial mastectomy and sentinel lymph node procedure. But prior to discussion of surgical change, Dr. Butler's provided us with some nice imaging typical of squamous cell carcinoma. Dr. Butler?
Thank you. As we all know, squamous cell carcinoma is relatively rare in the breast. From an imaging perspective, we have to be careful not to be tempted to assess these masses as simple or complicated cysts. They are, in fact, complex, solid and cystic lesions, albeit predominantly cystic. In this case, the diagnosis was made by aspirating the fluid and sometimes using a larger bore needle. Aspiration needle is helpful to provide the pathologist and the cytologist with the findings of keratin and squamous cells that help them to secure the diagnosis. But regardless, we notice that after aspiration, there is a residual mass, and there is some benefit to biopsying this residual solid component and providing the pathologist with further information.
Thank you. So with respect to her surgery, again, she was approached with a breast conservative lumpectomy and sentinel lymph node dissection, and we'll be asking our panelists to comment on both the radiation technique about the boost and also what would be the recommended chemotherapy options. Starting first with Dr. Mamounis, do you agree that squamous cell carcinoma is still a candidate for breast conservative treatment? And also, do you have some thoughts concerning the ductal carcinoma in situ close surgical margin?
Yeah, so this is an interesting case because it appears it has essentially two different histologies, but yeah, definitely metaplastic carcinoma or squamous cell carcinoma can be treated with breast conservation. It doesn't have necessarily a higher rate of local recurrence, and we treat it exactly like we treat other invasive carcinomas. The general guidelines, if you have invasive carcinoma with associated DCIS, is that as long as you don't have tumor on ink, your margins are good. This case is a little bit different because the DCIS is a separate entity than the metaplastic carcinoma, and the DCIS guideline, if you had a pure DCIS, says about 2 millimeter margin is the optimal margin. So you could sort of argue this both ways, that maybe she doesn't have an adequate margin for DCIS, but even the DCIS guideline with a 2 millimeter margin suggests that you have used clinical judgment and necessarily don't have to go back and re-excise everybody that has a 1 millimeter margin if it's only focal, like in one of the margins. So I personally probably would not offer additional surgery for a patient like this. She has a wide excision otherwise, close margin, but not involved with DCIS. And obviously she needs radiotherapy and adjuvant therapy, more importantly.
So Dr. Shah, tell me about your approach for cases like this. This is, again, a lady who with a breast conservative approach. Are you comfortable with the treating with a close DCIS margin, and how would that modify your decisions concerning radiation treatments?
So I would agree completely with Dr. Mamounis in the sense that, we have two guidelines, one for DCIS with 2 millimeters and one for invasive, saying if you have DCIS associated with invasive, no tumor on ink is acceptable. Even with pure DCIS, a margin of 0 to 2 is a clinical discussion. So I agree with him, no surgery. In terms of radiation therapy, I'd start in this case with whole breast radiation, given the metaplastic histology associated with the DCIS and the ER negative disease. I'd offer 40 gray and 15 fractions. In terms of the boost, the DCIS margin alone probably wouldn't be enough to push me towards a boost. But when you couple that with the ER negative metaplastic disease, I would recommend a boost, typically 10 gray and either 4 to 5 fractions, in addition to the whole breast radiation therapy.
Very good. Dr. O'Shaughnessy, triple negative breast cancer represents a whole variety of different subtypes. With this being a more squamous type of approach, do you consider that a little bit different than other triple negative breast cancers? And ultimately, what would be your recommended with respect to adjuvant care for her?
So with her, there are two issues. One is, what is her risk of a systemic recurrence? With this squamous metaplastic that's node negative as they generally are, because if they're going to metastasize, it's usually hematogenous, and they're at risk for lung metastasis, but it is only 1 centimeter. And then the second question is, if she wants to consider adjuvant chemotherapy, what is the best approach? So with the squamous cell carcinoma is so rare, I don't think we have really an estimate per se of that subtype of metaplastic very well. But in general, metaplastic TNBC is similar to other TNBCs in terms of prognosis. So I think we can use our TNBC prognosis for this patient. And with a 1 centimeter TNBC, I'd probably tell her she probably has a 15 to 20% chance of having a systemic recurrence. That's usually high enough in my mind to offer chemotherapy to her. In general, for metaplastic TNBC, the recommendation is to use our standard TNBC chemotherapy, either an AC taxane or an AC taxane carboplatin. Recently, there have been a couple of trials that have looked at taxane plus carboplatin preoperatively in TNBC patients. and are showing in one even small randomized trial pathologic complete response rates that are similar to an ACT or ACT carbo regimen. And so it turns out that in squamous cell carcinoma, that platinum-based regimens and docetaxel are agents that are effective in head and neck squamous cell, for example. So I would be really interested in talking to her about a docetaxel carboplatin combination. Either 4 to 6 cycles, I think would be, depending on how she was doing with it, would be quite reasonable. So that's probably what I would talk to her about. I think in general, if someone's otherwise healthy and we can, potentially reduce the risk of recurrence, albeit we don't have any real good adjuvant chemotherapy data in squamous cell metaplastic breast cancer in particular. But I think it's not unreasonable to think about that. And some of our TNBC chemotherapies work well in general in squamous cell carcinoma.
Thank you. So in conclusion, the panel would recommend proceeding with whole breast radiation followed by a boost component and also a consideration of adjuvant systemic chemotherapy, possibly with a carboplatin taxane backbone.